So look, the challenge was to talk about holistic care, where as it relates to cardiovascular disease in 10 minutes. And so I suppose what I thought I'd do is, these are the learning goals, but I thought I'd sort of really bring this down to self-management, because from my particular perspective, if I have a activated, engaged patient, I know they're going to do well. And then it's about sort of guiding them through their journey. And so that self-activation, that self-management is where I'm coming from. And I've sort of boiled it down to sort of 4 particular areas around education, self-measurement, adjustment adherence, which I'm really big on, and then health professional contact. And so when we first, so if we take the first one, education, I would hope many of us are very used to imparting information to our patients in a very sort of, educative, engaging way, not like the way I was taught when I was first graduated. And yes, I was guilty of lecturing patients about things. And we know that doesn't work, but using those sort of motivational interviewing techniques to get people to come on the road. But self-management, we know actually works best if it's a structured program that people can then participate in. And we know there's also an added benefit in group programs. And so the importance of cardiac rehab for our patients. And it's interesting when you actually look at some of the outcomes around all-cause mortality and cardiac mortality. If you think, cardiac rehab is a 6-week program, and the impact that it has on mortality over 5 years is actually quite enormous. So, so this sort of structured program, and I know there's a gap. My understanding is about 35–40% of people who've had an acute event actually end up attending rehab. And I've just heard today that there may be a hospital who's going to stop providing it, which I am aghast about, but these things happen. So that was cardiac rehab. We know it works. We know it's about empowering people, giving them understanding, knowing what they should do. And I think that's like the gold sort of standard. But even things like the coach program. So this was, trialed in St. V's in Melbourne, where people after an acute event had followed up phone calls. And it was really about how they're going with their medication. Did they know their numbers? Were they teaching their numbers? And, that in its own right ended up having huge impacts on people's health. And, that's been mainstreamed into a lot of public hospitals, a lot of the private, health insurers are now using it because it actually does work and keeps people out of hospital. I put the LIFE program only because I'm very closely attached to it. Certainly the LIFE program, and everyone thinks of it as being a specific diabetes prevention program, and certainly it's got a lot of evidence around that. A lot of people may not know that it was opened up for people at high risk of heart disease. Now, there's great evidence that comes out of this in terms of the diabetes prevention. I haven't seen any publications come out around prevention of heart disease. And I must admit, when I do look internationally at the follow-on of a lot of the diabetes prevention programs, there wasn't a huge reduction in, heart disease per se. But for those people who, the LIFE program is really about, learning, setting goals and working out how to achieve those goals. So if you're having people sort of struggling with that, that's still available. It's available online now as well. And of course, even simple things like walking and getting people involved in measuring their steps and quantifying them and improving them with time has certainly had improvement. And the high intensity physical activity seems to be more effective in the young, but walking seems to be really efficacious for our elderly. But then I really wanted to talk about sort of targeted action, you know, getting people, patients actually involved in their care. And, you know, for our activated patients, this can have great impacts. So I've got here around heart failure, you know, the flexible diuretic therapy where people weigh themselves every day. If their weight goes up 2 days in a row, that they increase their own diuretic. And so they're learning how to self-titrate. And that certainly reduces hospitalisation. And again, really important. And heart failure, you know, programs, they're actually, there aren't that many of them, and I like to see them increase. But they can also be referred to cardiac rehab as well, and they will get benefit from that. But if you can get people self-activated, monitoring, having that flexible diuretic therapy, they will do quite well. Now, Joe actually looked at the AF and the INR and said, what are we doing that there for? You know, no one uses, you know, warfarin anymore. But I put it there as a reminder that if this was a study done on people monitoring their own INR and self-adjusting their warfarin, and they did better than, you know, done by the standard lab thing. So, you know, I think to me, it was just a way of highlighting that, again, if we engage with patients in a real way and we give them control over what's happening around them, you can reap the benefits. And the last one is really about home measuring blood pressure. I'm doing this more and more. I love it. You know, my patients love doing it. And, you know, from the studies, you can see that there's improved adherence to medication. And, you know, overall, you do see a reduction in blood pressure. But, you know, I've actually had patients question me as to whether they should go on more medication. Now, you know, 10 years ago, 15 years ago, you would never have heard something like that. And it's just great to have that patient involved in their care. And so, you know, they feel like they have ownership. And to me, that's where I was sort of starting to come with that bent around holistic care. And, you know, the evidence is certainly there around blood pressure. And we teach it to our medical students, so it has to be correct. Isn't that right, Joe? But anyway, where it's really interesting is that when you look at health professional contact and evidence about when to review and why and how, you know, how often, there's no clear guidance on how often we should be seeing our patients. And so, I think that is very individualized onto our assessment of where the patient is in terms of knowledge, activation, health literacy, which I'm going to talk a little bit later on. So we often know patients that we sometimes have to work with more. And we also know that there are some fantastic patients who really self-manage well, who will come when they need to. But I can't tell you how often, there's no particular metric I can give you, but I think it's very much up between you and your patients. Now, I find this, I mean, even though it's a big table, I know it's very confused. I actually like it because it sometimes clarifies what it is I'm actually doing. So if you take the self-measurement, you know, why are we asking people to do it? So what's the purpose there? Is it them ownership? Is it around motivation? Is it to give me information into what, you know, what I should be doing? And who's the patient, who's the information for? Now, it can be both. So certainly with blood pressure home monitoring, you know, it's about all three, about the purpose and the information. But then it's what are they actually going to do with it? So is it, you know, is it reliable? But if you work out that I'm actually doing the measuring because I really want the information and I want to improve adherence to medication, then it clicks into that next one around adjustment adherence. And I'm quite happily saying to people, you know, your blood pressure is high. Yes, you know, home blood pressure, what I'm getting here agrees. you know, I'll get you to start a half of a tablet of something, you know, go away, measure your blood pressure. If it's above this and this, I want you to increase to a whole tablet, and then I'll see you again in 4 weeks or whatever. And, you know, to me, that sort of, you know, sort of partnership that we have in a patient, you know, really comes to that sort of, that respect that we need to be giving a lot of our patients to be able to do the things that they can do. So, but, you know, again, with education, it's, you know, what's the purpose, you know, who's you giving it and why. The reason why I've started with the self-measurement, because, you know, certainly around diabetes, there's been this great debate about self-blood glucose monitoring you all know about. People are doing blood tests for no particular reason, and it was of use, absolutely useless. So I think, again, it's a great way to sometimes think about why you do things, what you're trying to get out of it, and what's the use. And I think if we have clear guidance between us and the patient about what it is that we're trying to achieve and why, then they're far more likely to listen to what we want them to do, adhere with their medication, and their involvement improves. And I'd be very interested to hear from our Carolyn from the heart sort of rehab, cardiac rehab, because I'm sure that's part of what they do. But of course, not everyone can. And, you know, if you've got someone, you know, who seems to be struggling, doesn't seem to be taking on the message, you know, they're not just, you know, there's something going on. Do think of depression. We know depression is very common in people with heart disease. We know it has a bi-directional relationship, that people who have depressed are more likely to have heart disease, and people with heart disease more likely to be depressed. And so, you know, and it's something that we should be screening routinely for, because it's actually so common within our patients. And of course, if people are depressed, it has a whole impact around all the activities that we're asking them to do, including, you know, their diet, their activity, adherence. So it's really important. So the Heart Foundation came out with a statement, and that really we should be screening people with heart disease. They've suggested, you know, starting off with a screening question, the PHQ-2, and, you know, this, you know, we could easily add to care plans. It's very quick. Then if they answer yes to either of them, then, well, they say to go do the full PHQ-9. I just sit them down and have a chat and just try and sort out what's actually going on and where I need to do. But it's a simple screen, easy to apply, but may give you really important information that's going to help people move forward. And you can use the same sort of questioning in a variety of other diseases as well. But and so when you've identified them, in fact, the studies show that they do respond to treatment as our other patients do. So, you know, you can do the CBT. You obviously, you know, improving exercise is going to improve a lot of things, and you can actually use drug therapies, and they're safe. And so, you know, certainly SSRIs have certainly been shown to be a benefit. Of course, we're always very cautious around tricyclics and heart disease, but, you know, it's often forgotten. And look, sometimes in someone who's had, you know, who's got a very low EF, it can be very hard to sometimes distinguish between tiredness, disease, and depression. But if we really get down to that, you know, loss of enjoyment, that, you know, anhedonia, I think that's really important. So screen and somehow make it routine within your practice. Now, health literacy is a real big topic, and, you know, if we talk across the area of Melbourne, you know, we've got people from I'm just going dizzy with that, I'm going to have to move on. But health literacy, and this again comes into assessing how people, you know, understand what's going on, understand what it is that we're asking them to do, and again, these are just a whole stack of publications that show either that improvement in health literacy leads to better outcomes, or those with poorer health literacy do much worse. And so look, I won't get, I'm obviously not going to go through them all, but they're all there if this is something that you're really interested in, because again, you know, the size of the problem within Australia is often unrecognised. And, you know, we often talk about the teach back sort of type approach just to make sure that people actually understand what it is that we're saying. But again, really, really important topic. In terms of resources, because there's a lot out there, and, you know, the Heart Foundation has really improved or increased a lot of the resources around, they've got an online cardiac rehab program. Whether it's as good as face-to-face, I don't know, but certainly for people in remote areas, that may be a benefit. You know, they certainly have a lot of resources for people with heart failure, self-management guidelines that, you know, have simple, low literacy, you know, pictorial things that they can use to follow what it is that they need to do. You heard me talk about the coach program, and, you know, if you've got people who have private health insurance, you can certainly ask them to contact their insurer to see if they've actually got a coach program, because it does lead to outcomes, and it's obviously very, very useful. And in terms of finding cardiac rehab, you know, because let's face it, a lot of people on discharge from a hospital haven't been referred, and you can use the Director of Services to actually find a cardiac rehab provider close to you and actually do a direct referral. Because remember, again, we know that if you get them to rehab, they're going to do a lot better in the long run. So simple interventions, and, you know, I think the underpinning here is really about patient activation and self-management. Now, I thought I'd end up on GPMPs. I love GPMPs. I think they're great. You know, I do them a lot for people with diabetes, but I started looking for the evidence around heart disease. And so, you know, it's interesting when you do a GPMP with people with heart disease that includes physiotherapy, it can reduce hospital presentations. But overall, when you look at the data, there was another paper that said, no, it doesn't make any difference. And then if you look at claims for GPMP and then try and match them with Medicare or the admission data, it was an association that it reduced the likelihood of hospitalization. But that was actually for diabetes. So there's not a lot of information out there around heart disease. But where I come from is I still see GPMPs or care plan as a way of activating patients and involving them in their care, you know, common goal setting, and then making people account by doing the actual reviews. And that's it. I was going to keep it nice and quick.